HealthTech listeners, I'm your host this week, Justine Abson. This is the podcast where we tackle some of the trending topics, ideas and best practice across health and social care. This week, I'm delighted to have Jo Dickson, Chief Clinical and Quality Officer at Ramsay Health Care, and we're going to chat about some of the insights gained from this year's Patient Safety Congress, as well as how Ramsay Health Care is leveraging technology, AI and virtual care to enhance patient safety without replacing the essential human element across healthcare. We're going to discuss Ramsay's approach to building a just culture that empowers staff to speak up, their work with patient safety incident response framework, and why technology should serve as a supporting act rather than the main driver. So Jo, welcome to the podcast.
Thank you very much. Thank you for inviting me. It's great to be here.
It's so lovely to have you here in real life as well. And not just
amazing. It makes a nice change.
So can we start by you introducing yourself for our listeners?
Yeah, of course. So as you've said, my name's Jo Dickson. My official title is that I'm the Chief Clinical and Quality Officer for Ramsay Health Care. I also sometimes call myself the Chief Nurse or Clinical Director, depending on who I'm talking to, because I want people to understand what my role is. And the different titles sort of resonate with different people depending on who I'm speaking to. But I'm clinically responsible for the care that's provided in Ramsay's 34 hospitals across England. And so I work really with a really great team of people, all of whom are really focused on patient care.
Fantastic. I mean, 34 hospitals must be a little bit of a busy role.
It is a little bit busy. Every time I say it myself, 34 hospitals, I think, oh my goodness, how do I do that? But the reality is that I am not the one who's providing the care in those 34 hospitals. So I have to be able to trust those people who work in those 34 hospitals, which is really important. I have to trust them that they're doing their jobs and they're the ones who are providing great care for our patients. But it does come back to what we're talking about today, because actually my job in being responsible for 34 hospitals is made so much easier by technology. So actually, if I was doing it without technology, I would be having to go to every one of those hospitals regularly. Whereas because of the great technology that we've got in use, actually I can remotely do quite a lot of the things that I used to have to do in person, which is great.
Yeah.
So yeah.
Saves a few miles as well, doesn't
it? Certainly does. Yeah, it does. And means that I can stay in Yorkshire more often, which is always a good thing.
Always good. So I know you joined us when we did Patient Safety Congress, which is a few months ago now. But could you share some of the key takeaways from that event? Because it's such an important one, I think, especially when there's that role of technology across patient safety.
Yeah, I would say, I mean, it was a really great event. I'd not been to it before, so I felt really grateful that I'd got the opportunity to go, because I think sometimes in healthcare, and particularly maybe as clinicians, we can get a bit focused on the fact, well, yeah, of course, safety is at the heart of everything that we do. And you don't always take that moment to step away from the day to day and say, okay, actually, so what's new and different? What can I learn? How might I do things a little bit differently than I did them last year or the year before? So I find conferences like that really useful for that. The other thing that my really key takeaway was the power of collaboration. So both during the event, but also after the event, there was a big number of connections made with people that you then reuse those connections, don't you? And having conversations with people, learning how they're doing things is really great, sharing experiences. And I would say the other key takeaway for me this year was about patient involvement. I think we've always said that we had patient involvement, but I don't know that we have truly been able to demonstrate that until quite recently. And I think what's really great is that we are truly involving patients now in shared decision making. So it's no longer the fact that we do things to patients, and we should never have been doing that, but we certainly shouldn't be doing it now. So it was really great to kind of hear some of those stories that people were sharing about how they are able to really easily get patients involved in their own care.
That's a really key point, I think, about getting out of the day-to-day as well, because I think everybody does it, doesn't they? You're in that day-to-day, you're in your little cycle, and I think actually when you go and chat to people who are doing the same sort of things as everybody else, that shared experience, that if you just pick up that one little thing that you can take back to your hospital or a trust or whatever it is, that you can go, actually,
Yeah.
Why aren't we doing that?
Absolutely. And I think, I worked in the NHS for a really long time. So I worked in the NHS for around 20 years. And I now work in the independent sector, obviously. But Ramsay, we work really closely with the NHS. A lot of the work that we do is caring for NHS patients. So for us, it's really important that we have those strong connections to colleagues in the NHS, because actually we are doing things very much the same. And so we can learn a lot from each other. And unfortunately, it's not always possible to have those connections between the NHS and the independent sector, but it's really important because ultimately, particularly as clinicians, I think it's generally within healthcare, but particularly as clinicians, when it comes to patient safety, it doesn't matter that you're working in different organisations, or, we're not going to be sharing data that is, patient specific, for example, or in my case, commercial data. But actually, when we're sharing information for the benefit of patients and for the benefit of patient safety, that's a really great thing for us to be able to do.
Absolutely. I know one of my my key takeaways when I went to one of the sessions, and there was a lot of things in different sessions that were talking about that human element, which brings me really nicely onto one of the next things I want to chat about, because technology is so important. But like you said, I think you and the panel on the session we did capitalised on people first, tech second. So can you just tell us a little bit about what that means in practice and how it influences sort of the team across Ramsay's decision-making process, especially when there's so many new technologies as well?
Yeah, absolutely. I think that I'm really fortunate. So as I say, I'm a sort of chief nurse and clinical director now. But over the last 10 years, I have been involved in technology projects, clinical technology projects, and I've learned a huge amount over that time. So actually now, digital technology is not the main part of my job, but actually the skills that I learned during that time when I was doing technology projects is really, really valuable still. But the thing that I think I learned most during the time, and that I absolutely use every time, is that it is people first and technology second. So what I would say is the most important thing to do is to review where you're at now with the people. So look at your processes. Are the processes working? Are the processes working for your colleagues, for your team, but are they working for patients? Or are you putting blockers in for either your colleagues or for your patients that don't need to be there? And at the point that you're looking to then add in the technology, you can break some of those things that actually have needed to be the process steps that don't need to be there anymore. And that's not about the technology, it's about reviewing the processes. The other thing I would say is you have to review the processes at every point in them. And I think sometimes as clinicians particularly, we can get a bit fixed on the clinical part of the pathway, but actually the pathway, you have to look at the pathway from the patient's perspective and then review the process from the patient's perspective and see whether it's working. So it's really important that you do both of those things. You've got to change the processes before you change the technology, because otherwise every single person will think that the problem is related to the technology, and it hardly ever is. It's more often than not related to either the people or the process. It's hardly ever the technology that's the problem. So you've got to do those changes first. And then if you just put then the technology over the top of it, so long as the technology is easy enough to use, and that it will always be my mantra when I'm reviewing technology, is it simple? Can everybody use it, or is it so complicated that actually we're going to put people off using it? So look at the processes first, consider the people, including the patients, and then implement the technology on the top of it. And that's, I think, how you're successful in that kind of thing.
That process bit, though, is super important, because it goes back to that. Don't do something just because you've always done it. No. And so many, in any industry, people do that. And you do have to, again, that probably is where going along to something like an event or conference and things like that is where you then find those other bits and pieces that are different.
Yeah, and I think that's a really important point in terms of you have to look at it from that local perspective, because actually me going in as an external person to that hospital, I don't truly understand why a process works in the way that it works for those people who are using it every day. So you've got to empower those people. So I can't do that from afar. Obviously I can make sure that, for example, our executive team are on board and they're involved, and that they are supporting the project, and that they are making sure that the finances are there to support it. And that's my role within it. But actually the implementation of it has to be done locally, and the people locally have to feel empowered to make the changes that need to be made. So one of the things that I spend quite a bit of my time doing is saying, if you think the process is not working, change the process. Don't think that you have to get permission. I mean, obviously, there are some things that have to go through a governance process, and we've got really good governance processes in place, so people can ask the question if they're not sure. But actually, the people who understand why things work in the way they work are the people who are doing it every day. So it's really important that they feel empowered to make the changes that need to be made.
And that is definitely one of the issues, I think, then when adopting technologies that people then have, because sometimes I think, or far too often, they're sort of decided on, and by people that are not using it every day, who don't understand those bits that you've just mentioned, why something actually works that way.
It's to be honest, it's why I first got involved in the clinical technology project. So I was working in I won't say which trust it was, but fairly local to here, NHS trust, and they'd been trying to implement an electronic discharge advice note for 2 years. And just not really getting any traction with it. Nobody was using it. And it wasn't because it was a bad system. They'd had no clinical involvement in the project. So actually the IT team were coming along, delivering really great training with a product that was pretty good. But actually they hadn't engaged with the people who were going to be using the technology at the beginning. And that's why it just hadn't worked. So we just got people involved, got people to look at it, got people enthused about how this was actually going to improve their working lives. And then it's an easy sell, right?
Yeah, because that barrier, when you're already busy and under pressure and trying to, I mean, nobody likes to change anything technology-wise, do they? It's always such a big, your phone makes an update and everyone goes into panic mode. Yeah. But sorry, go on.
Sorry, I was just going to say something interesting, because it's a really important one for clinicians to remember about, because nobody likes change, and you're absolutely right. But as clinicians, we think things change every day for us. There's new evidence base that comes out for the treatments that we use. So people who are clinically registered, I would say, are pretty used to change. But sometimes they get fearful about technology change because they think this is not what I'm an expert in. I'm an expert in being a nurse or being a doctor or whatever your clinical profession is. So you get fearful of the change because it's about the technology, and you think, I'm not a technologist. And so actually having somebody that says, just think about this from the perspective of it's just a change. So actually you need to be trained on it. You need to understand it. It needs to be relatively easy to do. And then actually they're fine with it. But people sometimes get fearful because it's a technology change.
That's a really good point, actually. I've never sort of thought about it as that fearful of the technology as opposed to the actual change.
Yeah. And if you're an expert in something, which if you're a doctor or a nurse you are, it's quite hard actually to admit that you don't understand a different way of doing things.
And I guess it goes back to that, what you've just said at the beginning about the process bit of, by understanding why you're then making those changes.
Absolutely.
And then the impact on that day-to-day bit.
Yeah, absolutely.
It makes it a lot simpler, really, doesn't it?
Yeah, absolutely.
I know we mentioned at the beginning that Ramsay as sort of, you've used technology to increase transparency and foster a just culture.
Yeah.
And we've just mentioned, about making staff feel empowered is so important. So can you tell me a little bit more about how that works and the impact that's had, especially when it comes to staff engagement?
Yeah, absolutely. So it's probably worthwhile talking about a particular process that we use. We call it Speaking Up for Safety, or SUFS for short. we like an abbreviation in healthcare. Speaking Up for Safety. And we have Freedom to Speak Up, Guardian, and we have all of those kind of processes and whistleblowing policies, as you can imagine. But we use Speaking Up for Safety as a really specific thing, which is around our hospital-based teams predominantly, although it can be, is allowing them to really quickly and really easily speak up when something doesn't look right or doesn't feel right. And I think it's a really important thing for us to do is to clinicians or people who are working around healthcare, you'll sometimes just look at something and it just won't feel quite right. And you just want to be able to speak up and say, actually, can we just take a step back from this before we take the next step? And can we just decide whether whether something might be not quite right here? And that's when we use the Speaking Up for Safety process. And it fits really well then with all of that idea of empowering people to be able to say, I might be the most junior member of staff in this theatre, but actually that doesn't matter because I'm the one that's observed that somebody has just taken that, what should be a sterile piece of equipment, and they've just brought it in from somewhere that's not sterile, and they didn't realise because it's their first day here. And it's that kind of thing of, it doesn't matter what your role is within that setting, you are empowered to speak up and say, I want everybody else to be aware of this thing that I think I might have seen. And I think it's a really good basis for how we have those conversations. We also, and just cultures, it's really easy to say we've got a just culture. It's incredibly difficult to truly have one. And it's a constant thing that we talk about, is because lots of people within healthcare, we spent a really long time having things that was effectively a blame culture. And nobody did it intentionally. I know they didn't, but that is effectively what a lot of healthcare organisations had. So to move from that to a just culture is actually really, really difficult. We used to have the process of, root cause analysis was the way that we managed incidents and patient safety events. And if you're looking for the root cause of something, your kind of temptation always in that is to think that it's a person. It's somebody who's done something that they shouldn't have done. And that's the natural place that people tended to go to with root cause analyses. So moving away from that and moving to a different way of thinking is an ongoing training need for people. And just a reminder to people that, when they're working with each other, that we look at an incident, we look at a patient safety event, and we say, actually, let's look at the whole system. Systems thinking, it's really important. Let's look at the whole process. Let's say, what are the external factors that may have impacted upon that, rather than just saying, what was the single root cause of why that incident happened. So we use a variety of different things. I've got jumped from one thing to another there.
That's
Apologies,
fine.
Justine. It's kind of, it's about the people. It's about empowering them to say, actually, we do have a just culture, and therefore, if they observe something is that somebody is blaming somebody else, then actually they can speak up and say, that's not the way we work here.
Especially when, I know you touched on, when you're the most junior member of, in the surgery or wherever you might be, it can be really daunting to sort of speak up and actually. They might be the ones that are looking out for stuff like that because they're observing more and things like that.
Absolutely.
So to make them feel empowered
is
so important.
That fresh pair of eyes is so important. Yeah. And, we do have some really senior people in our organisation. Every surgical procedure in our environment will have a consultant surgeon performing it. So it is really, really difficult for people to feel comfortable enough to speak up if they want to. So we have to keep constantly reminding that is our organisational ethos is, everybody has absolutely the right and a massive request from us as a leadership team to speak up if they see something.
And that leadership team bit is, again, it's really vital that everybody's on board with that, because if that's the ethos and that's what, especially when new members of staff are coming in, new trainees, whoever it is, if that's the absolute ethos of the company and everybody's on board with that, it makes it a lot easier to embed that rather than to try and fight against it.
Yeah, it does. But it does come back to, for our organisation, what we were talking about at the beginning of the 34 hospitals, and how important visibility is. Because I'm not in every hospital. I can't even be there. So we use the PSIRF process, Patient Safety Incident Response Framework. So all of our hospitals have things called hot debriefs and after action reviews, and they do them really well. But I need the visibility of the kinds of outcomes that are coming out of those, so that myself and my team, who are an expert team in clinical quality, can feed back to those local teams and say, actually, your hot debrief, it probably didn't happen quite soon enough. You should have maybe considered doing it in the afternoon that the event happened, rather than wait until the next day. But without the visibility of that kind of information of how things have worked, that's incredibly difficult for us. So the local teams really are on their own if we don't have the visibility of it. So that visibility of information is absolutely key to being able to say, I'm going to speak up and, I'm going to say something's not quite right, because then people at a local level can get advice from experts around what is and isn't right.
And I think that's a really good point about talking about this, people first, tech second bit, because actually the focus is on the local teams to actually do what they need to do. But actually without that technology bit, you can't do what you need to do to then make the recommendations to then go back and make the improvements, I guess.
Yeah, absolutely. So it's really important, and that is exactly what we do. Is we don't review every single one, we can't, but we choose them, we look at them as a team. I've got some really great people in my corporate team who will provide advice. They are the ones who are also visiting the local hospitals, so we'll review things as a corporate team. We'll have a discussion about it, and then one of the team will then go and spend some time with the local hospital team and just say, this is the benefit that we've gained from having had a senior clinical team discussion about it, and these are the things that we think you might want to consider.
Fantastic. So we know, obviously, we've talked about, we don't want to lose the human touch in patient care.
Yeah,
that's absolutely so important. But also we know that there's a lot of like technology, a lot of AI now,
Yes.
which obviously is almost like I think some people are really terrified of it. Some people absolutely love it. But there are ways to use AI, obviously, in innovative ways. Have you got any examples of how sort of like tech has been used to improve safety across Ramsay without losing that human touch?
Yeah, absolutely. So it's interesting that you say some people love it, some people hate it. I guess I'm kind of in the middle. I do use AI, so I'm a user of things like ChatGPT and those kinds of things, and I find it really useful. I think the really important thing is that I use the AI to do the first step, and then I do the human validation part of it. And because I know that that's what I do in my use of AI, then actually that's kind of how we then use it in the way that we're doing things. So one of the really great ways that we're using AI is we're doing some work at the moment around our patient letters. So, you can use AI really well with speech to text and an understanding of, then moving that to a diagnosis for a patient. So there's some really great examples of that. The other thing that I think is really good around how you can do it is looking at trends and thematic analysis of stuff. So I'm going to mention, it's the first time I've mentioned the word radar, but I am going to say radar for the first time. Because obviously we use radar for our patient safety events and risk management, but we also use it for managing complaints, but also compliments, which is really important from our perspective. So we look at trends in our complaints, but also in our compliments, because you will have heard of never events, I'm sure, and we obviously monitor for never events within our organisation. But another term that's used sometimes in healthcare is always events, and I'm actually much more interested in always events, because from our patients' perspective, what should they always see from us as healthcare professionals, as teams who are caring for them in a hospital? And reviewing our compliments and thematically and analysing them means that you can determine what are those always events. Because what are the things that our patients want from us? And it possibly isn't the things that we think they want from us, because the things that are important to us sometimes are just expected by patients. For example, you come into hospital and you just expect your care to be safe. Why would you not? So actually the patient's not focused on that. They're focused on other kind of value add type things from you. So I think AI is great, but I think it's got to have the human validation, because all those themes come out and then you look at it and go, oh yeah, actually, but that's there because of this. And so you've got to have that human validation of it.
I absolutely love that you look for the theme and trends and compliments. We did a podcast a few weeks ago on appreciative inquiry. And it's one of my favourite podcasts I've recorded, because I love that you could do it in any industry. It's not just healthcare. But I love that when we were chatting about it, just understanding those little things that have gone well can help you change so much.
Absolutely.
Whereas I think that you mentioned earlier about root analysis and things, root cause analysis and things, like your instant thing is almost, well, what went wrong?
Yeah, absolutely.
And actually, there's so much that goes well.
People find it really difficult, though. So it's been a thing for quite some time now, where lots of organisations will have a patient story, for example, at the beginning of an executive team meeting. And this isn't just my organisation, because I've done a bit of reading about it, because it's in others as well. What typically happens is that people bring patient stories where things have gone wrong. Because when they look at a patient story and they see things have gone really well, everybody just goes, well, that's the job. Of course it went well. That's how it should go. And so everybody just puts that down to, that's just the day job. So of course it should go well. Why would we talk about that? But actually there's so much value in talking about when things have gone well. You absolutely have to talk about when things have not gone so well and how you're going to improve from that. But there's huge amounts of value in celebrating when things go well and making sure that is then repeated.
Well, that was one of the conversations we were having as part of the episode we did was, I can't remember if it was Katie or Kaylee mentioned it, but they switched a meeting. So instead of starting with what went wrong, they started with what went well. And they both said it sort of completely not only flipped the whole dynamic of how everyone felt. So even when they were then discussing what went wrong or what didn't go so well, it felt a lot less sort of blame
absolutely.
culture than it would have done. And it stopped everybody sort of leaving feeling like they'd done the worst job possible.
Absolutely.
When actually, going back to the human element, nobody wants something to go wrong.
No, they don't.
So actually, just by having that little shift at the beginning,
Indeed,
just changed the sort of the feeling in the room of then what you could discuss by the time you got to the what went wrong, basically.
It comes back to the processes as well.
Yeah.
Because you've got to look at, so what happened in the process when it went really well? How do we repeat that process for every interaction that we have?
Absolutely. And that brings me really nicely onto, you've touched on patient safety incident response framework.
Yep.
We'll call it PSIRF because obviously it's, healthcare, obviously. So how has PSIRF influenced your approach to incident reporting and then how you learn from those incidents?
Yeah, hugely. So it's been a really big change for our organisation, but one that's been really accepted really well, and people are now really enthusiastic about PSIRF. We have some really great conversations, and I think the shared language that PSIRF gives you is actually really valuable. I was talking earlier, wasn't I, about, the NHS and the independent sector. Having a shared language around patient safety is actually really valuable to us because you know that you're comparing apples with apples. And in the past, I'm not sure we always were doing that. So I think PSIRF, that sort of standard process, standard language is really helpful. I love that it's in real time. So I'm one of those people who used to find it really frustrating. So that you would, because I can remember this. I'm old enough to remember that you used to kind of get your incidents and kind of the information of your incident. You'd get it 3 to 6 months after that incident had happened.
Wow.
Because there'd be a root cause analysis which would take 90 days, and then somebody would need to get the report. They'd need to adapt the report. They'd need to sign it off, and it'd need to go through 2 or 3 different committees before you, as the person at the front line, got the information about how you could improve that pathway. That's not the case anymore. And I think that's a brilliant thing that PSIRF does. It's real time. So you have a hot debrief with all of the people involved in a patient safety event as close to the time that event happened as possible. You then stop it from happening the next day. And that's incredible, right? Because that's definitely not where we were 10 years ago. And I think it's so great that we can learn in real time. We can implement new processes to make care safer, such that the patients, even, the one patient after that patient, is safer than they were before, which I think is really fantastic. It comes also back to that kind of visibility side of things. I've got 34 hospitals plus a 3 sterile services unit plus a mobile diagnostics fleet. So they're MRI and CT scanners that travel around the country. Lots of the incidents that we review, although they'll happen in one of those facilities, the learning from them will be pertinent to all of the others. Yeah. So for us, the use of technology means that we can learn really quickly in one part of our organisation and then share that learning more widely. And PSIRF, again, that shared language, that shared way of doing things in real time and sharing the learning means that everybody's doing that. So, I quite regularly on my team very regularly get calls saying, we've had this happen, letting you know about it. We did the hot debrief. This is the lesson learned. Can we share it more widely? Yeah. That's brilliant.
That bit about being able to make improvements instantly. There'll always be improvements you can make that, longer term ones and things like that, without a doubt. But to be able to do something that could potentially save somebody's life the next day is, especially when, like you've just said, 10 years ago, you could potentially wait 6 months to get that information. How many other patients have potentially gone through the same sort of thing that could have been stopped?
Yeah.
No, I think
very good.
It is. And I guess that's where the technology then does help with that.
It's
not only there that helps with the real time bit, but helps with that faster improvement side of it and with that analysis around the themes and the trends.
It does, because we have standard templates that we put into Radar. So when our colleagues are, using hot debrief or an after action review, they use a standard template, they fill it all in, then they put it into Radar, and then the people with the right role-based access control, of course, can then see it wherever they are in the organisation. So you don't have to go there to be able to see it. You can do that from wherever, so that is invaluable, I think, for us to have that.
It's a huge leap in change and things, isn't it? 10 years is a long time, but in reality, it's not a long time as well. So when you sort of then think, another 10 years, I wonder wonder where things will be is interesting.
Well, I can remember before we had systems when you used to have a carbon copy book. That's where you used to record your patient safety incidents, and you'd do it in the book, and it would be carbon copied, and you used to have to try and make sure that you could write it through, because it was sometimes the case that you used to have to send off the top copy to corporate. I did that in inverted commas, you can't see me, sorry. And send it off to corporate, and they would get the top copy, which was written really well. And then the carbonated bit just sat in a book that somebody would look at some point in time. But it really wasn't very good. So I can't believe actually that things have moved on so much from that in what is actually a relatively short space of time.
Does it make you wonder how anything almost got analysed or changed or improved or anything, doesn't it?
Yeah. I mean, the reality is that the care we're delivering now is so much more advanced than it was 15 years ago, that we've got to be using technology, because, our patients, their care is being delivered by using technology.
So we've just literally mentioned about, how our technology is kind of helping. And you've mentioned about, the importance of combining that with the expertise of staff and patients. Yeah. Have you got can you share how kind of you engage your patients and staff in sort of co-designing the tech solutions? I know you mentioned at the very beginning, getting clinical on board from the very beginning is so important. But I think that collaborative approach really does improve care outcomes, doesn't it? It
does, yeah. And we, so one thing that we do still struggle with a bit is getting patients involved, being really honest with you. We're an elective care organisation. So actually, most of our patients, they come and they have elective care with us, and actually then they get back to work or their life, and it can be quite hard to engage them. So we tend to try and focus really a lot more on our own colleagues. So for us, that's really important that our hospitals are relatively small in the grand scheme of things. So we always look at it from the perspective of the whole of the pathway. So it's not about us getting all of our doctors in one room, all of our nurses in another room, and all of our administrative staff in another room. That just wouldn't work for us. So we have to get these things co-designed with the pathway in mind. So we tend to look at it from that perspective, and we say, right, we're going to look at, for example, the pre-op assessment pathway, and we're going to look at all of the pain points in that pathway, and we say, what's working today, what's not working. We're really lucky. We have a team of people who then can test that out with patients, and we get patients involved. We do market research to say, what are the pain points for our patients? What's working well with the technology that we've got, and what's not working so well. I think we find it relatively easy as an organisation to get our colleagues involved. I don't tend to have a shortage of people saying, yeah, I'm happy to help, or we'll be a pilot, or, people are generally really happy to engage and support. I think part of that is because in the past, they maybe have had the situation where, they got told that they were getting a new EPR in 2 years' time, and what happened was that, 6 weeks before it landed with them, they got trained on it, having had no involvement in how that was actually going to work at the point that it landed with them. And so I think now people are much more open to the idea of actually, if I get involved in this early, then I can have my voice heard and I can contribute to making sure that this is a usable system. So it's not typically something we have a problem with getting people engaged. What we do need to make sure is that we get a variety of different people engaged, because you don't want it to be that only people who are very tech savvy are involved. So you do need to make sure that, you'll always have that situation of your early adopters, your fast followers. And we do build on that. We do use those people because they're the people who will, I guess, give up their time willingly because they want to get involved. But if you don't consider those people who are going to be your naysayers, you're going to have a problem, really. So we do try and involve those people who maybe aren't as digital and data literate. We've actually got a programme that we're just kicking off at the moment, because we've recognised, even though we've got a lot of technology, we've got an electronic patient record across all of our hospitals. But even having said that, we find that not all of our people are digitally and data curious. Yeah. So they learn how to use the systems that they need to use for their job, but they're not necessarily thinking, how can I make this better? Or how can I use the skills that I have in my working life, in my home life, or vice versa? So we are just kicking off a big piece of work around digital and data literacy. And what we're trying to do with that idea is get as many people involved as possible. We're not sitting there as a kind of senior leader leadership team saying everybody should be more digital and data literate, because that just isn't going to work. So what we're trying to do is find people in our hospitals who are keen to learn, are curious about how they can improve their skills. And we've been really, really careful that we say this is about digital and data literacy, because data is one of the things that we have not, I think typical of many healthcare organisations. People have kind of put the technology in over the last 10 years, but they haven't necessarily understood what data that now gives them and then how they can turn that into information. So all healthcare organisations are creating huge amounts of data, but actually there aren't enough people who've got that understanding of then how do you use that data to be able to improve patient care? How do you make patients safer? And how do you make their clinical outcomes better based on the data that you're collecting about them anyway?
That language about being data curious as well. Yeah. I mean, like you just said, we know healthcare organisations are collecting so much of this stuff.
Yes.
But actually, if you're not curious about what it's then given you and what you can do with it and how it can interlink with, your other systems and things like that, then you could potentially be collecting data that's you don't really need to be doing.
Absolutely.
Versus actually, there could be something that you go, well, actually, why aren't we getting that bit? Because that actually would link really well with that system. Yeah. And that could tell us something mind-blowing.
Yeah, almost. Absolutely. And we've got to do that across organisations as well, because that's the other thing is, we have to share lots of data with lots of other organisations, NHS England, for example, we also submit data to the National Joint Registry. So there are a huge number of data collection points. And we just, as organisations, need to get better at kind of pulling our own data together. And in order to do that, you've got to have people at all parts of the organisation interested in what they might do with that data.
Well, exactly, because somebody that, carries out a lot of the audits, that's what they're interested in. Yeah. It doesn't mean that, somebody sat in finance is interested in that, or a surgeon is interested in that, but they're going to be interested in something completely different.
Absolutely.
But it also doesn't mean that it can't all link together and actually help everybody along the pathway that it could help with.
Yeah. Yeah. It's interesting. I used to work with a CFO, so Chief Financial Officer, who he must have been very ahead of his time, because he always used to say, he said, safer care is more efficient care, so cheaper care. Yeah. So if you can make care safer, it will be less costly to deliver. And that's true. Yeah. But that means that everybody's got to be looking at the data with those types of things in mind. And, it is about making it safer. But then, if you are saving money or making money, then actually you can then reinvest that into other things and other services. So there's just so much, and it is about, as we say, everybody in the organisation being bought into that idea.
I think as well, one of the barriers that seems to come across quite a lot as well with the technology side is, apart from the fact that people haven't been brought into it, is that a lot of the time it gets sold in as this will solve all of your problems.
How many times have I heard that?
And it's never going to solve every single problem. But I think, again, I think people that are going to use it every day, if they're sold this dream and then it doesn't do every single thing that they thought it was going to do, is, again, there's just that sort of clear lines of understanding what things do. Yes. Understanding what they can do.
Yes.
So obviously there's the wider bit, but just understanding that it's not going to fix absolutely every single thing.
Absolutely not. And also no one single system is going to do everything as well, because that's the other thing that I think sometimes people find quite difficult, is that, they have to now really, to do their jobs, most healthcare professionals will have to be using, I would say, probably 5 or 6 different systems for different parts of their job. And unfortunately, that's just the reality of it, because your e-rostering system, for example, can't do the same things as your electronic patient record can. There is some overlap, and there might be some ways of making sure that data is connected, but actually you're still probably going to have to use both systems.
Yeah. And I think that, again, that comes back to, it's great when they talk to each other and you want that, because that is going to help with that collaboration of the data and everything else. But it is about making them easy to use.
Yes.
Especially when you're trying to log into a few different ones to then do what you need to do with it.
Yeah, it does. But it does come back to the data, because one of the risks at the minute is that we're collecting lots of data in the different systems that actually, if you were to put that data together, then actually that's really powerful. Yeah. Because, if you can look at your workforce data in your e-rostering system alongside how many patient safety events you've had in a particular theatre, and you can see whether there's a correlation between your skill mix, which there is, spoiler alert, the correlation between your skill mix, the correlation between your skill mix and your patient safety events, that's really powerful to learn about, because it enables you to put the right skill mix in a theatre to make sure that there is a less likelihood of having a patient safety event.
Yeah. And we've talked obviously about where we've come from. We've talked about years ago and the carbon copies and things like that. So now I just want to chat a little bit about looking ahead.
Yeah.
So what excites you most about the future of tech in healthcare, and what challenges do you think organisations need to be aware of and need to sort of forward think about?
Yeah, so you've already mentioned it, but it's the next step for AI. So for me, ambient AI, I think, is the thing that I'm most excited about. I used to find this when I worked clinically, and I know lots of colleagues feel the same. People get really frustrated at having to write things down. So it's really frustrating when you've worked an 8-hour shift and you want to make sure that you've recorded information about your patients for that time. So you spend, I'm going to say on a good day, half an hour, but sometimes much more than that, as part of that, each shift that you're working, writing down the things that you've done. I'm just really excited for a time when, for example, a doctor can sit in an outpatient clinic and there will be AI in the room that will be able to listen to the voices. It will be able to truly do shared decision making with a patient. So, procedural consent, you'll do it in a true shared decision making process with the patient, but actually all of that will be captured using the AI, and the documentation of it, you won't need to worry about. Of course, you'll want to validate it, but absolutely that it will be done using AI, and then it will be recorded. And we won't spend our time just writing things down for the sake of writing things down. So that's one thing I'm quite excited about. What I would say is the biggest challenge is sometimes people like me in leadership positions can have a bit of a want to go faster than the organisation is ready for. So you've got to get a balance there, because there's got to be people like me who are interested in the future and can see a way of us, using technology for really good things. But you've got to make sure that your organisation is prepared for that before you go down that route. Because, we talked to him earlier about digital and data literacy. We've got to make sure that our people are in a certain, an educated enough place for us to be able to be doing some of these things. I would say that the other thing that is a challenge sometimes is allowing time for collaboration. People have got really busy day jobs, and so it can be difficult to free up time for them to really collaborate with each other. And then the other thing that I think is a challenge is, how do you prioritise it? Because there's so many different things that you could pick from, and how do you choose what's right? And what's right for my organisation and my team, might not even be right for other people within my own organisation, never mind everywhere else. So it's really hard to kind of prioritise what you should do and when you should do it.
Yeah, I think that's where that collaboration piece comes in a little bit as well, isn't it? If that ethos is there, if everybody's kind of on the same page in terms of what do we need to improve, what do we need to achieve, that could help with that prioritisation across the different teams to understand why you're doing one thing first. Yeah. Even though you might prefer something different. Yeah. I think that's...
And that's, I feel really lucky in the organisation that I work in, because we do that collective prioritisation. It's really difficult sometimes, but we do always try to do that. And so it's not that, for example, one of our other directorates, their needs and wants would take priority over those of the clinical team or the operational team, or, we do try and truly collaborate in order to prioritise so that we're thinking about all of our people. We're a smallish organisation. We're not tiny. I mean, we've got about 6,000 or 7,000 colleagues, so it's big enough that we do need to, and it's quite hard then to prioritise. But you've got to collaborate if that's what you're going to do.
I think you have to understand why you're doing it like that way as well, don't you? To understand that actually their needs aren't taken priority.
Yes.
But actually, by doing that, that improves.
Yes.
That bit, and then actually you sort of got, right, okay, I get why that one's coming first.
Yeah, we're in the process at the moment of we currently don't have a maintenance management system, and we're looking at buying one. So when it's obviously it's owned in a different part of my organisation than mine. So when my colleague came and said, this one what I want to do, I'm kind of looking for support, and I said I'm hugely behind that, because if we've got a maintenance management system, that means that I know when our anaesthetic machines were last serviced, or when our maintenance engineers checked the airflow in our theatres, and that's all recorded and all of that information is gathered. That really helps me to understand more easily where we've got safety challenges. But actually, if you were to look at it as it's just a pure maintenance, it's, looking at it from a maintenance management system, why would the clinical lead be interested in making sure that happened? So that's why it's really important that we look at things collectively.
Yeah, I absolutely love that. I think it's something that everybody listening could take away, even if it meant they worked with one more department more collectively.
Yeah, absolutely.
It's never going to happen overnight, but I still think it just shows that importance of why these things all link together.
Absolutely, yeah.
So finally, I think you've already answered this at the beginning, but I think we'll go back to it anyway. What advice would you give to healthcare leaders looking to adopt new technology while maintaining a focus on their people and their care?
I would say my biggest one, being somebody who has worked in digital, now working back in a pure clinical leadership role, don't be scared that other people know more than you do. I think sometimes when you get into a leadership position, you think that you have to personally know all of the answers. You don't, you can't. And so it does come back to the collaboration point. You've got to work with those people around you, but don't be scared. People sometimes, I think, particularly with technology, are fearful because if they say, I don't understand that, they think that is makes them less able to be a good leader. It doesn't at all. The best leaders are the ones that say, I don't quite understand that. Can you help me to understand it? So I would say, don't be scared that others know more than you. Embrace opportunities, embrace change, be curious. That's absolutely something that I think is my mantra. And just, talk to people. I love talk. You've probably already realised, I'm sure all of your listeners have also realised that I like talking. And, I think it's a really great way of us understanding more about each other, but also understanding more about our patients and how we can make care better for them.
I love that bit about don't think you need to know everything, because I agree. I think, again, you sort of feel like you should, but everybody has their strengths. Yeah. Everybody comes into particular job roles because they're good at what they do.
Yes.
So you have to trust everybody in their own individual remits. And actually, nobody knows everything.
They don't.
People that own companies don't know everything.
Absolutely, they don't.
Everyone has those strengths that make them good at what they do.
They do. People who own successful companies have successful companies because of the people around them and because they lead those people well. It's not because they on their own are brilliant, because nobody can be that brilliant. It will usually be because they've got great people around them and they are good at leading them.
Yeah, I think that's an absolutely brilliant tip, because I think that again empowers the people that are in charge of those particular roles or those particular teams or however it might be at whatever level. Yeah. Empowers them to make those decisions and kind of decide what's best for the role they're in and the impact on the business.
Yeah, absolutely. Yeah.
Fantastic. Well, I've absolutely loved talking to you, Jo, and I'd love to get you back on when with the digital and data literacy. Once that be rolled out, definitely. I'd be really interested to hear about how that's happened and sort of what's happened on the back of it as well.
Well, I might suggest that I bring one or two people with me when I do that one, because it won't be me that's making that change happen. So it'll be other people within the organisation at all levels. Yeah. But I might find a couple of good people, but we'll definitely come back. Yeah, no, that would be great. I think that would be something that'd be really interesting that people can take away as well. So at the end of every episode, we like to ask everybody what the health tech moment is. So this question's a bit of fun. It doesn't have to even be tech focused. It's just, kind of something that's happened across your career in healthcare that always makes you remember it. Okay, so it does have a tech focus, but it's about people. So I don't think of myself as a techie person. I did work, as I say, in technology for quite a while, health technology for a while, but I don't think of myself as a particularly techie person. But one of the most emotional moments that I've ever had was one of my nursing colleagues, so one of my team in a previous role, stood in front of a room of about 40 software developers and made them cry. and the way that he made them cry. So he is still a clinical digital nurse, but he was a critical care nurse. So he worked in ICU. And as is usually the case with clinicians, we find it quite difficult when we come out of clinical practice, particularly I think if you're moving into digital roles, because at first it can feel like you're really far away from the patient and you think, oh my goodness, I'm not making a difference to patients anymore. And we were able to demonstrate to him what a difference he was making that day when he made 30 grown men cry, because we actually were developing our own electronic patient record. Crazy idea, don't suggest anybody does it, but that's what we were doing. And we were implementing what was the process of risk assessing patients for their VTE risk. So it's your risk of getting a blood clot or in your leg or your lung typically. And when you're in hospital, if you've had surgery, you are more at risk of having one of these blood clots. And the team of developers were the people that had developed within the system the ability to code people. And we used to kind of traffic light them as to their risk level. So they were green, they weren't at particular risk. Amber, they had a little bit of risk. Or red, they were at significant risk. And because they had built it in the electronic patient record, he was able to show them the data that a patient had had their VTE risk recorded. They'd therefore been started on treatment really early in their pathway, and they'd been prevented from having an episode, which would have meant that they potentially had died. And so those 30 software developers never came into healthcare because they thought that they were going to have a direct impact on somebody's life. Really did. And it was incredible. And they all were in tears. And my colleague remembered why he was both a nurse and a digital clinician.
That is absolutely amazing. I think that's that point about actually like developers and people behind the scenes, if you like. Again, they don't really always know that impact of the day-to-day, do they? So.
Absolutely. It's why, sort of thinking about stories for that, it's something that stuck with me. That's probably 10 years ago now, but it stuck with me because it's just, really important from both perspectives. It's really hard as clinicians to not always be thinking you're making a difference for patients, but you are. And then also, as you say, for people behind the scenes to really understand what an impact they can have for patient care.
I love that story. I think that is such a lovely way to end the episode. So thank you for sharing that with us, Jo, and thank you so much for coming up today and recording the episode with us. It's been
worries.
fun.
Thank you very much for the invite. I've really enjoyed it. Thank you.
Thank you so much for joining us this week, Jo, and thanks to everyone for listening. Join us next time for a brand new episode. Don't forget to rate and subscribe, and if you've got any questions for us or our guests, please email whatthehealthtech@radarhealthcare.com.